Good evening and hello everyone. There are a few things that you must all be, aware of. This is a new class, 2021. We have started with a new session, and this session would start with the chapter number 1 of Robbins. Now, our textbook to follow would be Robbins, but ensure that we are not reading Robbins. I again repeat, our textbook to follow is Robbins, right? But we won't be reading Robbins line to line. What does it mean? It simply means that I would be teaching on the pattern of Robbins, but you have to read Robbins yourself. So I won't be underlining Robbins for you. That is your job, and that you should do it quite well. But if you choose to read any other textbook, that's very, very fine with you and me, because ultimately when I teach, I ensure that the entire concepts of Robbins are well put in front of you. When I start this class, I have a few things to say to myself and you, that let's be very logical in understanding concept, because I feel that pathology is one of the most logical subjects of the entire 19 subjects of the MBBS. Everything we talk about is based on the your knowledge of anatomy and physiology. So what I am assuming is that you have a bit of knowledge of anatomy and physiology. That means, see, we'll use a term here, etiology. We'll use the word pathogenesis. We'll use the word clinical features. So if you read the first few chapter and pages of Robbins, it talks about that what is etiology. Anything which is causing a disease is called as etiology. Okay, because of those etiologies, some changes occurs biochemically and physiologically in a cell, that is called as etiopathogenesis. Because of those pathogenesis, there are some features with which the patient presents with, and those are called as clinical features. And along with that, there are some morphological changes occurring in a cell, which is called as morphology. Now, these morphological changes may be either visible only in microscopy or may be visualized in the gross morphology also. Like for example, a kidney shrinking in size. So when the kidney shrinks in size, suppose the cause of a kidney shrinking in size is hypertension. So hypertension becomes our etiology. Because of hypertension, suppose the blood vessels gets constricted, maybe because of deposition of some hyaline or protein. So this is the etiopathogenesis. Once the vessels have constricted, the patient's presence with hypertension or maybe hematuria, this is called as clinical features. But the kidney shrinking in size may be visible in the gross morphology or may also be visible in the microscopy. So that is called as morphological changes. Okay? So there's a few basic things you should be aware of. I will talking a lot about etiology, etiopathogenesis. I'll talk about clinical features and as well as morphology. Okay? Then today we'll start with a new chapter, and one thing please understand, that in Robbins we're talking about the 10th edition, right? So I will not be calling it again and again Robbins, because that will make the things very tedious and too difficult to understand. So I'll be using a word textbook. Okay, so in the textbook of pathology, you will see that the first chapter is based on the cell. It talks about the cell, unit of life. But I won't be taking that today. My topic of today would be cell injury, adaptation, and cell death. That is the first chapter of, I would say, general pathology per se. Now, when I talk about this cell, I will first ensure, yes, I will first ensure that you do hear me very well. So, for those who have just joined the group, yes, very good evening to all of you. Krish, Chaitali, Chetri, Sai, Gaurav, Sagar, Shrenik, and Sagar. So, yes, what we'll do is we'll try to take the concepts very slowly, but ensure that everything is quite clear to you. At any point of the time that you don't understand, you may put that doubt in the Telegram group, but I won't be taking that doubt in the real time. I would be taking the doubt after every 1 hour or 1.5 hours. Okay, this is our rule. This is a rule between you and me. Other faculties may take it differently. They may take the time. They may take the doubt at that time. I won't take the doubt because that will actually disturb the rhythm of the class. Yes, I'll ensure to go a bit slow because it's a first class, and as you say, I may pick up the speed later on. Okay? So we'll start with the first topic of the chapter. The chapter is called as cell injury, adaptation, and cell death. Okay? So the first topic of today's will be cell injury, adaptation, cell death, and this is what a cell is actually made up of. What is this? Now, if you talk about the cell, let's describe the cell here first. The cell here is actually having, this is the plasma membrane, right? It's a plasma membrane. This is the nucleus, right? It's a nucleus, and this is the nucleus actually. Now this is the nuclear membrane. It's a nuclear membrane here. Okay, this is the nucleolus. So this is the chromatin and the matrix, you can say, the chromatin and the matrix that you read. One thing you all know, that the outer membrane of the nucleus is actually continuous with the endoplasmic reticulum. So this is the endoplasmic reticulum. Now if you see the ribosomes attached to it, these are ribosomes here. So this becomes what? It becomes a rough endoplasmic reticulum. There are some smooth endoplasmic reticulum as well. Okay, there are some smooth endoplasmic reticulum as well. But apart from this, you may also see this might be a Golgi body with the cis and the trans end. This might be the Golgi body. Okay, it may be Golgi apparatus. So Golgi apparatus, if you remember, it has some, cis end and has some trans end, if you remember all of this. So this, the protein that is actually synthesized by this, goes to the cis end, and after packaging, the protein comes out of this trans end. That is very basic thing that you all have read. Okay. Now, this is a mitochondria, the powerhouse of the cell. Okay, it's a mitochondria, and this here is a vesicle. These all are the vesicles. These are the ribosomes now lying free, even though ribosomes are quite attached to the endoplasmic reticulum to make it the rough endoplasmic reticulum. But yes, a few ribosomes may be found here and there. Now, these all here, you see these are actually called as the cytoskeletal. Okay, they're called as cytoskeletal. Okay, that means these are the fibers which make the shape and size of a cell. They are the ones which make shape and size of a cell. So they ensure the cell has a unique shape and size, that they don't disturb the shape and size every time. The cytoskeleton protein is made up of either a tubulin, they are made up of actin, and they may be made up of microfilaments. The microfilaments you might have read about is cytokeratin for an epithelial cell, vimentin for a mesenchymal cell, and so on. Okay, so these actually are the cytoskeleton proteins which ensures that the cell is of proper shape and size. Okay, this is what you must know. Now, whenever a cell is in its normal functional state, that state is called as homeostasis. Okay, now suppose the cell is functioning well and good, everything is fine, the cell is performing its all usual function physiologically, so we will call that cell to be in a state of homeostasis. Okay, now whenever anything goes wrong in that cell, the cell physiology may be disturbed, the cell may not be functioning well, so that is when the physiology will change to pathology. So welcome to the second year. Now we'll be talking about anything going wrong in a cell, which is called as pathology. Okay, so let's make this in a form of notes. Cell injury, adaptation, and cell death. Okay, cell injury, adaptation, and cell death. Now we'll talk about the normal cell, and that normal state of a cell. Suppose this is a cell, guys. If this is a cell, the cell has a nucleus and everything. There's a nucleus, there's an endoplasmic reticulum, and all those I just mentioned, the mitochondria, ribosomes, and everything here. So this state of a cell, when a cell is functioning normally, is referred to as homeostasis. Okay, this is referred to as homeostasis. So in short, if you ask me, sir, exactly what is homeostasis, I would be using the term, it's a normal physiological state of a cell. It's called as normal. It is called as normal physiological. Please understand, normal physiological state of a cell is called as homeostasis. It's called as homeostasis. Okay, it's called as homeostasis. Normal functional state of a cell is referred to as homeostasis. Now, the point is, what may go wrong in a cell? So, can anything go wrong in a cell? Plenty of things can go wrong in a cell. Suppose the cell, which is functioning normally, suddenly has an ischemic injury. Do you know what is ischemia? Ischemia means decrease in the blood supply. So suppose this normal functioning cell suddenly has any sort of injury. Now I'm not saying it may be a physical injury. If this undergoes any form of injury, okay, this any sort of injury, the cell will have to change its functional state. So what may happen? I'm drawing it three types. Dekho. The three ways how a cell can change its normal function. The three ways how a cell can change its normal function. The first of them can be if a cell undergoes any form of stress. Now you might be asking, sir, what is stress? Well, we undergo stress. How can a cell undergo stress, sir? Yes. Because what happens sometimes a cell can undergo stress in the form of increased workload. So whenever there is an increased workload, suppose you have an increase in workload, you have an MBA exam, what do? You study from 4 hours a day. I think I've got it more. You study from 1 hour a day to 10 hours a day. So you are increasing how you can work. Similarly, so that increase MB, that MBA exam is a stress for you. And so you all adapt to that MBA exam. You study more. Similarly, when a cell has a stress increase in workload, the cell undergoes cell adaptation. So adaptation is a new state of a cell in which it can modulate itself to work more or work differently. So what are the types of cell adaptation? There are basically four types of cell adaptation. It may be hypertrophy. It may be hyperplasia. It may be metaplasia, or maybe atrophy. Okay, there are four types of cell adaptation. It may be hypertrophy, hyperplasia, metaplasia, and atrophy. Similarly, if you look at the next form, suppose this was the stress, right? It was stress. The second form of injury that can occur to a cell is a mild form of non-lethal injury. Now when I say mild form of non-lethal injury, I mean it can be mechanical injury, it can be physical injury, it may be a chemical injury, it might be a ischemic injury, it might be a free radical injury, it can be any sort of injury. So this injury I will mention it separately below. Then what are the types of injury talking about? So let's write it here. So the injury here can be a physical injury, it can be a physical injury, it can be a chemical injury, it can be a free radical injury. Okay, it can be a free radical injury. Okay, it can be a free radical injury, it can be a thermal injury, it can be a thermal injury. Okay, thermal injury. It can be a ischemic injury. You know what is ischemia? Just write in bracket, it is decrease in blood supply. Decreased blood supply. So whenever there is a mild non-lethal injury, the cell undergoes a form of injury called as reversible injury. Okay, it undergoes a form of injury called as reversible injury. Okay, reversible injury. And this causes a type of change, morphological change. The morphological change that you expect in the cell now, it is called as hydropic change. Hydropic change. The morphological change you expect in a cell now is called as hydropic change. Hydropic change. Okay? Now let's move to the third one. What happens if this injury goes to be very severe injury? That means suppose the cell undergoes a severe form of lethal injury. So what is a severe lethal injury? The same form of injury. It can be a physical, chemical, ischemic, it can be free radical, but that becomes to such an extent that this injury become irreversible and it is persistent. That severe lethal injury, this will change a cell to form a irreversible injury. Okay, it will cause irreversible injury. Irreversible injury in a cell, it's of two types. It can be necrosis, or it can be a form of injury or cell death called as apoptosis. So when I say irreversible injury, I simply means cell death. Okay, I simply mean cell death. So this is where we begin the chapter today, telling you what are the forms of injury and what are the morphological changes occurring because of those injuries. Okay? If there is a stress, the cell adapts itself. The four types we'll talk to today: hypertrophy, hyperplasia, metaplasia, atrophy. Then we move to mild non-lethal injury. The mild non-lethal injury we'll talk about is morphological change in the form of hydropic change, okay, in the form of hydropic change. The hydropic change we'll talk about here, okay, and finally we'll talk about the irreversible injury called as necrosis and apoptosis. Finally, we'll talk about actually three more, I should say: necroptosis, pyroptosis, and also pheroptosis. So later on, we'll talk about here. We'll add three more here. So 3, 4, and 5. I'm writing a bit a newer form, which is necroptosis, pyroptosis, and pheroptosis. So these three are a bit new. These three are a bit new entry to the form of injuries. So make sure that you know also these three also. Okay, make sure that you also know a bit of these as well. Okay. So this is the basic introduction of the all forms of injury. I hope you've written this down. So the first topic of today's will be sorry. We'll not talk about this cell adaptation. Okay, let's talk about cell adaptation. So what do I mean by cell adaptation? As I told you, it's a new state of a cell because of the stress that has happened to the cell. Okay, so adaptation, remember, they are reversible forms. Adaptation, they are reversible changes in either the size, okay, either the size or the number or the phenotype. That means how do they look like, phenotype, or the metabolic activity. So any of this change which is due to the new state of a cell is called as cell adaptation. It's called a cell adaptation. We'll take this one by one. Let's start with the first two comparing together, that is hypertrophy and hyperplasia. Let's talk about the first two together. It is hypertrophy and hyperplasia. So we'll make a table here discussing two of them together: hypertrophy versus hyperplasia. Okay, now if you follow the new textbooks of pathology, the cell adaptation has been mentioned after the reversible and the irreversible cell death, but that is not how you should follow. You should start with the basics first, and the basic is hypertrophy first, then hyperplasia, then metaplasia, then atrophy, and then move to the reversible form of injury. Let's start with the definition first. So hypertrophy actually means increase in the cell size, whereas hyperplasia means increase in the cell number. Okay, increase the cell number. So this, in very most simplest way, if I talk about this, let's assume this is a patient brain, and I'm drawing here normal here four normal cells like this. Okay, these are four normal cells with the nucleus. So in hypertrophy, what will happen? The arrangement will be same, the cell size will increase, and so will be the nuclear size like this. The nuclear size will also increase like this. This is called as hypertrophy. But when I talk about the hyperplasia, what will happen? The cell will again be normally arranged with the same size, but the number will increase. Normal arrangement, but the number will increase, and this will be called as hyperplasia. Simple difference between hypertrophy and hyperplasia. Very simple way to understand this. Next to understand is, why does it happen? That means, what is the stimulus? As I told you, the stimulus is for both of them is same, it's stress. increase in workload. The stress is actually same for both, that is increase in the workload. Okay. Next, what is a mechanism? What is the mechanism? See, the mechanism for hypertrophy is synthesis, increased synthesis of the structural proteins. Increased synthesis of structural proteins. That is what happens in hypertrophy. I'll talk about how does it happen mechanically. But hyperplasia occurs because of cell division. In simple, it is mitosis, increased mitosis, which brings upon the hypertrophy. But remember, even hyperplasia, sorry, even though there is mitosis, it's controlled mitosis. The machinery of the cell has still a control over this mitosis. But when it goes uncontrolled mitosis, that becomes a cancer. So we're not talking about that uncontrolled, it's a controlled cell division. Controlled cell division. Finally, the biggest question to ask here is, sir, if both of these are same, if both of them are occurring because of the same stress, why are they different? Why the morphology becoming different? Morphology of one of them is increase in cell size, morphology of one of them is increase in cell number. So why? The reason is both of them are different type of tissues. Whereas those tissues which cannot divide will undergo hypertrophy. Those tissues which can divide will undergo hyperplasia. Okay? Those tissue which cannot divide is undergoing hypertrophy, and those tissue which can divide will undergo hyperplasia. Now once you know this, let's now see the examples. Like when I talk about those tissue which cannot divide, so what comes to your mind physiologically when I say these tissues cannot divide? Those cells which come to mind which cannot divide are the nerve cells, the cardiac cells, and the skeletal muscle cells. The same example comes here also. See how? If you break them into physiological examples and the pathological example, let's talk about first physiological examples of hypertrophy and hyperplasia. Dekho, I told you those tissue which cannot divide, and what comes to mind first? Skeletal muscles. Now, suppose a person is building his body, Salman Khan. So he builds his body, he has those big biceps, and there goes a few months when he's not able to exercise much. Everything goes down, his stomach comes out. That means this is a reversible change because of more workload. What is the more workload? Dumbbells. Yes, the exercise machine. So skeletal muscles in athletes as well as in the bodybuilders. In the bodybuilders. Okay. Next one is uterus. Uterus in pregnancy. Uterus in pregnancy. And breast. Breast in puberty, pregnancy, and lactation. Breast in puberty, pregnancy, and lactation. Breast in puberty, pregnancy, and lactation. Okay. Now we move to the physiological changes in the for physiological examples in the hyperplasia. Here comes the example of uterus again. Uterus in pregnancy. So this is a, sometimes students get confused. So you are telling uterus in pregnancy as an example of hypertrophy, and now you're calling that example also in hyperplasia. So where to put it? My answer is both of them. Both of them will come under hypertrophy and hyperplasia. Okay? Uterus in pregnancy goes into both hypertrophy and hyperplasia. Then comes the breast. In breast, mostly in the puberty, and pregnancy. Okay, so it is believed that the breast in lactation mostly undergoes increase in the size of the acini, and therefore breast in lactation usually is example of hypertrophy only, and usually not the examples of hyperplasia. Okay. Now, apart from this, can these occur in as pathology also? Yes, they can. Let's now see the examples, pathological examples. So first of all, you must understand what is the difference between the physiological examples and pathological examples. Those things which are a part of the normal physiology of a cell, it is physiological examples. But something which occurs because of a wrongdoing. For example, suppose there is a cardiac muscle undergoing hypertrophy because of hypertension, it becomes pathological examples. Okay? Dekho, I'm trying to say is a cardiac muscle can undergo hypertrophy due to hypertension. So because hypertension is a pathological change, this becomes a pathological hypertrophy. But if you look at the pathological examples here, like the estrogen, okay, like the estrogen or the effect of androgen, देखो, now see, whenever there is an increased amount of estrogen in the female, the endometrium can undergo hyperplasia. But that estrogen increasing may be due to some tumors. There are some tumors like of the ovary which increase more and more estrogen. We'll talk about this in certain pathology. So that becomes an endometrial hyperplasia, but that endometrial hyperplasia is not normal. It's an abnormal finding, and therefore the endometrial hyperplasia would be a pathological examples there. Similarly, androgen like the 5-hydroxytestosterone, I mean short form 5-HT, causing BPH. What is BPH? It's a benign prostate hyperplasia. Benign prostate hyperplasia, BPH, benign prostate hyperplasia, BPH, can cause basically hyperplasia of pathological type. So one thing to understand is these examples are very, very important to solve the questions of the first chapter. I first talked about what is the difference of hypertrophy hyperplasia. I'll show the images also. I then talked about what are the examples of hypertrophy and hyperplasia, and I have divided these whole examples into physiological and the pathological changes. Now this is very, very important. Make sure you know the detail of this here. Okay, this is very, very important. It is very, very important here. Okay, pathological and physiological examples. Let's see the images now to understand this in a better way. See, let's start from here. Now what you're seeing here, guys, this here is a cut section of the heart. Okay, it's a cut section of heart. Now whenever the heart has any hypertensive changes, the heart muscle undergoes thickening. Look at the thickened heart. Okay, now compare that heart normal and this heart which is abnormal. What you're seeing is increase in mass and size of the organ. Morphologically, there is increase in mass and size of the organ. Now what I did, I took a biopsy out of it. So if I took a biopsy, I see this. Let's see this image in a higher magnification. This is the one. If you compare the biopsy on the left side, let's see how the heart muscles are there. It's a branched muscle like this. This is a normal. It's a heart muscle like this. Okay, look at the thickness. This is the thickness, right? Now compare this heart muscle here, which is a branched muscles, to this muscle. Look how thicker now the muscles are. Look how thicker they are. Okay, this is how thick they have become. So from this size, they are becoming such thicker muscles. So because they become very, very thicker here, this is what is hypertrophy. Eventually look at the nuclear size also. Very, very large nucleus also happened here. Again, it is hypertrophy. It's hypertrophy of the cardiac muscle. This is the biopsy taken from the skeletal muscles. So these are the red fibers, the sarcolemmal fibers, and these are the normal. This is a normal biopsy of the skeletal muscles. Okay, it's a normal skeletal muscle biopsy. Compare the image you see here on the left side and compare this to the right side. Look how enormously the muscles have increased in size. So this is what it is, again, is hypertrophy. Why? The size of muscles have increased. It is what? It is hypertrophy. It's hypertrophy. Okay? Let's see a few more examples. Look at this one. Now this is an interesting one. If you see, this is what? This is a uterus. Okay, this is a normal uterus. And this is an enlarged uterus. It's an enlarged uterus in pregnancy. It's an enlarged uterus in pregnancy. Now what we have did, we have to taken a biopsy from the normal uterus and shown here. This is a normal uterine biopsy. Now, why is this a normal uterine biopsy first of all? Why? Because you see the spindle shaped cells. Look at the elongated spindle shaped cells. And why the spindle shaped cells? Because they are smooth muscles. They are spindle shaped normal cells. Spindle shaped normal cells. Look at this blue color spindle shaped normal cells. Compare this image to the biopsy taken from the pregnant uterus. What is happening here? Look at the enormously increased in the muscle size. Enormously increased muscle size. They are spindle shaped, no doubt about it, but look at the enlarged size. Now, if you look at them carefully, even the number of these cells will be enlarged. Even though this is showing which is hypertrophy, But eventually, when you see this in a more illustrative manner, you'll appreciate that this also has a increase in the number of the cells, and therefore a uterus in pregnancy shows both hypertrophy and hyperplasia. But if you have to choose one answer, look at the image here. The better answer to choose here will be hypertrophy. So we will write later on that hypertrophy will be more than hyperplasia. So this is how the MCQs are also placed. That sometimes they put a MCQ like a uterus in pregnancy shows both hypertrophy and hyperplasia. That is the best answer. But sometimes they don't give an option of hypertrophy and hyperplasia. You have to choose one of them. In that case, we'll choose an option of hypertrophy over hyperplasia. Okay, few more examples. Look at this example. Now this is a normal prostate here. This is a bladder, urethra, and look how the prostate is located there. Okay, and this you're seeing is an enlarged prostate here. The prostate enlargement is usually due to the increase in the 5-hydroxy testosterone, which is the male sex organ. It's male sex hormone. Okay, now look at this normal. This is a normal gland of a prostate. It's a normal gland of a prostate. So this is the gland area. Okay, I'm writing just G here. This biopsy is of normal gland here, and this is the stroma. This pink area is the stroma. This pink area is that of stroma. Okay, the gland and the stroma. Now, whenever there is an increased effect of androgens, what happens? The gland will increase and stroma will also increase. Both of them will increase. When the gland number and the stroma number increases, this is how it looks like. You see, the gland number have increased, and so the stroma has also increased. The stroma has also increased. So gland and stroma, both of them have increased in the number. I'm writing G for gland and S for stroma, as you might have understood this. So the moment you see increase in the number of glands and the increase in the number of stroma, this becomes a BPH, benign prostate hyperplasia. This is how the morphology looks like in a gross morphological point. This is where the urethra passes. Okay, and look at these big nodules you are seeing. So these nodules, when you look at these nodules in a microscopy, this will show something like this. So because I am seeing increase in the gland and increase in the fibromuscular stroma, my diagnosis here will be BPH, benign prostate hyperplasia. Technically, because of the increase in the prostate size, the urethra is not able to void easily. The bladder is not able to completely clear itself. Because bladder is not able to completely clear itself, the patient's presentation will be hesitancy. He may not be able to pass easily urine. He will increase frequency. Because he is not able to pass, the bladder will keep on filling multiple times. So increased frequency, hesitancy, increased frequency, urgency. So he will find an urgency to pass urine. And ultimately, because of the more stagnation of urine in the bladder, the patients may have a recurrent urinary tract infection. He may have a recurrent urinary tract infection also. So this is what you must know and understand, as this may cause the BPH, benign prostate hyperplasia, benign prostate hyperplasia. Okay, so two of them are discussed together. One was hypertrophy and one was hyperplasia. Let's see this again. Cardiac muscle, hypertrophy. Skeletal muscles, hypertrophy. Uterine muscle, hypertrophy and hyperplasia. Both are there, but what is more? Hypertrophy. And this is the BPH, benign prostate hyperplasia. Benign prostate hyperplasia. Okay. Now, before we end this topic, let's see. It's a not very simple thing to understand for you as of now. But as you move into the chapter detail in later on, you'll appreciate what I'm talking about. This is about the biochemical mechanisms. Biochemical mechanisms. Okay, biochemical mechanisms of myocardial hypertrophy. Okay, so this would be more clear in the later half of the topics, but right now just make this myocardial hypertrophy. Okay, that means we talked about hypertension causing myocardial hypertrophy. So in myocardial hypertrophy, what was happening is, suppose this is a normal muscle of the myocardium, the branched muscles. I hope you remember the branched muscles like this. So we understood that these branched muscles are undergoing hypertrophy like this. ठीक है, this is the normal nuclear size, okay, and this is the enlarged nuclear size here. So my question is, what are the changes in the biochemical process that causes hypertrophy? देखो, what happens is there is increased mechanical stretch. There is increased mechanical stretch. So whenever there's increase in mechanical stress due to hypertension or whatever, this is due to increased workload. It is due to increase, due to, I'm writing it to, due to increase in workload, okay? Due to increased workload. Now, as you understand, because of more workload, the myocardium has more amount of blood. So because of more amount of blood in the myocardium, heart muscles will stretch more. Similarly, whenever there is a action of alpha adrenergic action, alpha adrenergic actions, or there are some hormones, example angiotensin, again the heart may have to contract more. Similarly, there are some factors, growth factors, example insulin like growth factor 1, IGF-1, which also has an effect on the heart muscle, so what happens, these three things together, they basically stimulate the cardiac muscle again and again. They stimulate the cardiac muscle again and again. So when they stimulate the cardiac muscles repeatedly, what happens, the cardiac muscle has increased transcription factors. They have increased transcription factors. For example, there are factors like GATA, they are factors like NFAT, and they have MEF2. There are some transcription factors. I don't think that you need to detail of this. This is the short form here. I'll discuss about these in detail separately also. There are increased transcription factors. For example, there is a GATA4, GATA4. Okay, there are NFAT and NFAT, and there are MEF2. Okay, MEF2 is myocardial enhancing factor 2. NFAT is nuclear factor activated T cells, and GATA is all about the GATA is a transcription factor which binds to the DNA. Don't go to detail of this. Just try the short form because they are known by the short forms only. So once this happens, what happens is, because of these all, there are three things again. What happens is, there are increased growth factor production again, and because of increased growth factors, the growth factor again causes the same thing. They'll again keep on increasing the size of the cell. Similarly, there's increased contractile protein. There increased synthesis of the actin, that is contractile proteins. Now this will allow the heart to cause more effective contraction. Okay, this will cause effective contraction. Okay, effective contraction of the heart. And one more thing that it happens is, it will change the induction of the fetal genes. Okay, this will increased the induction, increased the fetal genes, increased fetal gene expression in the cardiac muscle, increased fetal gene expression in the cardiac muscles, because of which, see, what happens is, there is a two types of fibers you might have read in physiology in the cardiac muscle. There is an alpha fiber and there is a beta fiber. There is an alpha isoform and there is a beta isoform. There is an alpha and there is a beta isoform. So what happens during hypertrophy of the cardiac muscle, the alpha isoform, which is of the myosin heavy chain, will change to the beta isoform. Okay, the alpha isoform, this will cause the alpha, that is the adult isoform of the myosin heavy chain, MHC, will change to the beta isoform. The beta isoform is a fetal isoform. It is a fetal isoform of the myosin heavy chain. Now, because the beta isoform, there is more effective contraction of the heart. This also causes effective contraction of the heart. So when you're writing this, what do I mean by this? Dekho, first write it. Basically, the reason of any cell adaptation is to perform in a better way. Do you agree? For example, you had an MBA exam and eventually you are reading for the 1 hour every day, and suddenly you are reading for 10 hours a day. Why? Because you want to perform well. You don't want to fail in the exam. You don't want to get less marks. You want to get better marks. So because you want to get a better marks, you are working more effectively. Similarly, when a heart muscle has faced some situations like the hormone action, the alpha adrenergic actions, there's a mechanical stretch, the heart also wants to work better. So how does the heart work better? They increase the transcription factor genes like these three, the GATA, NFA, NFAT, and the MEF2, and these causes more effective contraction and also causes cardiac hypertrophy. It also causes cardiac hypertrophy. So this is how the heart muscle will cause the cell adaptation, and the effect I've already told you. I'll just show you that again. The effect is this thing. Look how effectively the heart has increased the contractile proteins. They have increased the alpha isoform to the beta isoform. So this heart muscle, you see, this heart muscle, where you're seeing this increased size, this will cause more effective contraction, and this will persist till the time those injury stimulus are there. If you treat hypertension, this may go back to the normal. If you don't treat hypertension, this will keep on increasing and eventually the heart may fail. But that becomes a pathological change. We'll see later on in the upcoming topics. Okay, so this is the one that you must know. If you're not written, please write it down. Now, if you have any doubt till now, you may also ask me. So before I move forward to the next topic of metaplasia and atrophy, I'll be able to answer this. So one of the doubt you're asking me is, in athletes their systolic volume is increased. So what is the relationship between hypertrophy and hyperplasia with systolic volume? So see, why does the systolic volume increase? I think you're not showing systolic volume, you're showing stroke volume. So why does the stroke volume increase? The stroke volume increases because of more effective contraction. So because of more effective contraction, the stroke volume is increasing. Now question is, why does the effective contraction occurs? Because of these reasons. Okay. So what is the relationship between hypertrophy of patient systolic volume? These are the reasons why the stroke volume increases. Because without of this, it may not increase the stroke volume. Okay, it may not increase the stroke volume. In fact, because you just talked about this, please understand that there's something called as athletic bradycardia. Okay, the athletic bradycardia is a physiological change. The athletic, just add it here. There's something called as athletic bradycardia. So athletic bradycardia is a physiological change in the heart in which there is again hypertrophy, but that is not a pathological effect. Okay. Look, hypertrophy may not undergo hyperplasia, but sometimes they will occur simultaneously. Yes, they may occur simultaneously. Hypertrophy hyperplasia may sometimes occur simultaneously, but not always. Now, if you ask me, sir, will hypertrophy and hyperplasia will never occur together? I'm not saying that. But sometimes you have to understand that one of the morphological change is more compared to the other change. Okay? Chalo. So let's move to the next topic here. Let's move to the next topic here. The next one is metaplasia. Our next topic will be metaplasia. So how do you define this topic of third one? Metaplasia. Okay. Metaplasia is defined by in pathology as it's a change in the phenotype. Okay. It is change in phenotype. It's a change in phenotype due to. Now there are a few definitions that you must know before we move further. So what is metaplasia? Basically, a change in phenotype. The change in phenotype is a condition where suppose a cell looks like a squamous epithelial cell. The squamous cell is now looking like the columnar epithelial cell. The change of phenotype has occurred. So metaplasia basically is a change of the phenotype due to stem cell reprogramming. Stem cell reprogramming. Okay, to stem cell reprogramming. Okay? In other words, it is change of one type of differentiated cell, change of one type of differentiated cell by another type. The reason of this is a stem cell reprogramming. Let's talk about this separately also. That what is the basic stimulus? Why does it happen? The stimulus for this is actually a chronic irritation. Okay, it's a chronic irritation. The stimulus for this is a chronic irritation. Let's understand here what are the types of metaplasia. Okay, what are the types of metaplasia? The types of metaplasia, it can be epithelial, or can be connective tissue, Okay, I'm talking about the types of metaplasia. It can be epithelial, it can be connective tissue. Okay, now see, understand this carefully. Epithelial type can be again of two types. It can be A, squamous metaplasia, or it can be B, columnar metaplasia. Squamous or the columnar metaplasia. The connective tissue metaplasia is a condition where the change occurs in the connective tissue like muscles or the bone. So that's one good example. I'm starting an example straight away. It is myositis ossificans. So in this condition, what happens? In the myositis ossificans, what happens? There is a change of the muscles. Basically, there occurs a dystrophic calcification in the muscles. Now, the term may be a bit difficult for you right now. First, you write it down. There occurs dystrophic calcification in muscles. In simple word, the calcification is a property of bone. The muscle don't have calcifications, right? So that means the muscles have been replaced by bones. The muscles have been replaced by the bones, and hence we call this metaplasia. Hence we call this as metaplasia. When we come back to this one, among these, remember the most common type of metaplasia is squamous metaplasia. What I'll do is I will take these two metaplasia separately to make you understand the concepts. Let's start with the first topic of A, squamous metaplasia. Squamous metaplasia. Dekho. Now, our memory is very short. If I ask you, what do you remember about 2020? Well, everyone has the same answer. So nothing but the Corona COVID. That means, have we forgotten the good things happened in life in 2020? We've almost forgotten, because what is important for us is the rest what has happened recently. The point I want to make here is, because squamous metaplasia is defined as any other epithelium. It can be any other epithelium. It can be columnar, it can be cuboidal, it can be transition, doesn't matter. Any other epithelium replaced by the squamous epithelium. Replaced by the squamous epithelium is called as squamous metaplasia. It's called as squamous metaplasia. It can be any other epithelium. Remember this example. Dekho. The first example you must remember here is A, in the respiratory system. In the respiratory system, a person who is a smoker. The respiratory system normally has what? Ciliated, pseudo-stratified columnar epithelium. Because of smoking, the ciliated, pseudo-stratified columnar epithelium will change to squamous. So, first example is smoking. Next is COPD, which stands for chronic obstructive obstructive pulmonary disease, COPD, like the chronic bronchitis, and vitamin A deficiency also. Vitamin A deficiency also. Okay. B. It can be in the bile ducts or in the pancreatic ducts. The bile duct or the pancreatic ducts. The bile duct or the pancreatic duct, like for example, stones, okay, stones and infections. Okay, stones and infections. Suppose the bile duct has a stone. So you all know that all ducts have cuboidal epithelium. That cuboidal will change to squamous because of the stones or the infections. Again, the new epithelium is what? Squamous. It is called as squamous metaplasia. It's called as squamous metaplasia. The third one, the C here is in the bladder, urinary bladder. So bladder normally has the transitional epithelium. Because of the stone or the infection by schistosomiasis, it will change to the stones, or by the infection of schistosomiasis, it will change to the squamous epithelium. Will change to squamous epithelium. The next one example is the endocervix. Next example is endocervix. The endocervix, not ecto. You all know ectocervix has squamous epithelium. The endocervix normally has the columnar epithelium. Now, whenever the columnar epithelium has a change in pH, okay, there's a change in pH, there's any change in the pH, or there is a human papilloma virus infection, HPV infection. Again the same thing happens. It will all change to the squamous epithelium. Will all change into squamous epithelium. So 4 examples: respiratory system, bile duct, pancreatic duct, bladder, and the endocervix. All of these have different type of epithelium, but whenever the changes occur, will change to one common type, and that common type is squamous epithelium. And therefore the example of this comes under the example of squamous metaplasia. I told you, any other epithelium changing to squamous epithelium is called as squamous metaplasia. It's called as squamous metaplasia. Okay? Now, I'll just draw one image to make you understand it better. I'll show you that. Look at this one. Now, this same image came in this year's NEET also, the NEET exam, NEET PG exam obviously. What happens? This is the respiratory system. It's a respiratory system here. Now, what you're seeing is, this is the columnar epithelium. Okay. Now, look at the cilia here. This is cilia. Okay. It is cilia, and this is a column-like cells. You see the column-like cells? Okay. Now, compare this image to what you see here. These cells here, these all are the squamous epithelial cells. These all are the squamous epithelial cells you see here. So what you're seeing is the column-like cells have changed to, the column cells here have changed to the squamous epithelial cells here. And this is the basement membrane, guys. This is what? It's a basement membrane. Okay, it's a basement membrane. So what I'm trying to say is, the normal epithelium was this one, has changed to the squamous epithelium, and therefore I call this squamous metaplasia. It occurs in smoking and the chronic obstructive pulmonary disease. This is the image also, you must understand. The same image actually ciliated pseudo-stratified columnar epithelium has changed to the squamous epithelium, and hence example of squamous metaplasia. Okay. Now this image again, you see there is the column-like cells here, and this is squamous epithelial cell. Okay, so this is one other image how it may be seen, but right now look at this. Is a better image for you to understand. This is what you see. The columnar epithelium will change into squamous epithelium, and hence it is squamous metaplasia. In fact, the most common type of metaplasia is the squamous metaplasia. Let's now move to the next type of metaplasia, that is, this is what? Squamous, the most common type. We now move to B. What is B? Columnar metaplasia. Now move to B. columnar metaplasia. ठीक है. Again the same definition I can put. It is any other any other epithelium any other epithelium replaced by which one now? Columnar epithelium. Okay, any other epithelium getting replaced by columnar will be called as columnar metaplasia, will be called as columnar metaplasia. ठीक है. Now see the example. One of the best known example for this is Barrett esophagus. Okay, Barrett esophagus. Now what is Barrett esophagus? To understand this, let's see an image again. We'll come back to drawing that again. देखो, let's see an image here. Let's see this image first. What you're seeing here, this is the esophagus, guys. This is esophagus and this is stomach. Why? Why? Because this looks a shiny white in color. See, the squamous epithelium is usually recognized in the gross morphology by looking at the color. Now this is whitish in color, the shiny whitish in color. Now because of the white color, remember, not exactly white but the pale looking color, I should say pale, this actually is what? It's a squamous epithelium. Okay, this is squamous. When you move to the stomach, it's red in color. Look at the shiny mucosa. Now this is columnar. Okay, this is a normal thing. And this is the gastroesophageal junction. The big question is, why does the stomach has column epithelium? The reason is this area has a acidic pH of nearly close to 1. And this pH can damage the epithelium of the stomach. To prevent itself from the getting damaged, it has a layer of mucin over it. This glazy appearance, the glazy shiny appearance is because of mucin here. Now, the mucin is coming not from the squamous, it comes from the columnar epithelium. You all agree with this? Now, this columnar epithelium has a mucin lining because of which the stomach can prevent itself from getting damaged by the acidic pH. Okay? Now, suppose a patient has a problem in which all his stomach content is going up. That is back. It is called as GERD. This is called as GERD, gastroesophageal reflux disease. This is the GERD. Now what happens, guys? The GERD, gastroesophageal reflux disease, what happens that the acidic pH from the stomach, it will go back to the esophagus. So this area gets inflamed and gets inflamed red in color. It gets inflamed red in color. So when you take a biopsy from here, okay, when you take a biopsy from this part, it will show what? It will show the changed epithelium. From the squamous epithelium normally, this area will again need to prevent itself from getting damaged. To prevent itself, it needs to adapt. And that adaptation comes in the form of columnar epithelium. Here. So when you take a biopsy, what will you see? But first question is, from where you take a biopsy? You take a biopsy from the lower end of esophagus. So see, this is a biopsy taken there. Esophagus normally has squamous. Now, if this biopsy has been taken from the lower part of esophagus, so lower part of esophagus should also show squamous. But what is happening is, this part from here to here, you see, it is all columnar epithelium. It's all columnar. How do you say? Look at this column-like cells and look at the nucleus at the base. Look carefully. You'll see this. There's a nucleus at the base and all of them are column-like cells. Look at this again, column, and the nucleus is towards their base. So this is what? It's a columnar. It should have what? Squamous. The squamous has changed to columnar. Not only the columnar, one cell is very striking here, and that cell is this cell. Look at this one. What is this? What is this round thing? These all round white looking area are the mucin. These all are the mucin areas. Okay, these are the mucin areas. Okay, now this mucin is released by a cell called as goblet cell. Okay, it is released by a cell called as goblet cell. Okay, the goblet cell is releasing mucin, and now you see a goblet cell normal position is in the intestine. The goblet cell being found in the stomach is something wrong. And what is wrong there? This stomach will need to protect itself by releasing mucin via goblet cells. and therefore this has now been present there. The moment you have seen that goblet cell here, the moment you have seen the goblet cell here, this is a hallmark of Barrett esophagus. The question is how to identify goblet cell. Very, very simple. Dekho. Do you know what is the literal meaning of the word goblet? The word goblet refers to a wine drinking glass. A wine drinking glass like this. ऐसे. ठीक है? Now, this is how the goblet look like. And this is the mucin area. This white area is the mucin. This is the mucin you see here. These are the mucin. The cell below this, see, the cell below this will have this shape, isn't it? And this shape looks like a champagne glass, right? Look at this. If you draw this, it becomes a champagne glass. Now, this typical glass, the champagne glass, is a goblet glass, wine drinking glass. This wine drinking glass cell is called as goblet cell, and the presence of this in the lower part of esophagus is virtually diagnostic of Barrett esophagus. It is virtually diagnostic of Barrett esophagus. So let's draw this image in our own notes to understand this better. There you go. So what we have drawn till now, what we understood till now is that this is the esophagus, right? And this is the stomach. The stomach, as you all know, has which epithelium? The stomach has columnar epithelium here. Okay. And this area, esophagus, has squamous epithelium here. Okay. So this is what? Squamous. This is what? Columnar. Okay. And this has an acidic pH of close to 1. The moment the acidic pH goes to the lower part, this part here also gets inflamed. This part here, it also gets inflamed here. Acid. Okay. Now this lower part here, the lower part here has got inflamed. Because it has got inflamed there, because it has got inflamed here, this will be what? It will be, yes, Barrett's esophagus. Okay, so the moment you take a biopsy from here, let's assume you take a biopsy from this part. Okay, if you take a biopsy from this part you take a biopsy from, what it will show? This should have shown the squamous epithelium, but it will no longer show squamous. It will show the tall column-like cells like this, and this is how it should look like. As okay, and where is the nucleus, guys? This is where the nucleus is, in the at the base, towards the base. Okay, now see, this is the goblet cell. Okay, G-O-B-L-E-T. Goblet cell are these. Sorry, this is the goblet cell. Okay, the goblet cells are these, and what they release mucin here. Okay, you will see a big area of mucin here. Mucin. This again is a mucin. Okay, these all are the mucinous area. ये mucin है. This is the mucin area. I'm writing M here. The big question is, the mucin is completely white in color. They don't stain at all. So to confirm mucin, there are some good mucin stains. Let's write that. The mucin stains, there are two of them. One is called as mucicarmine. One of them is mucicarmine, and one of them is Alcian blue. One of them is mucicarmine, and one of them is Alcian blue. They are the mucin stains. Mucicarmine and Alcian blue. Now this will confirm that yes, there is mucin there. The goblet cell, as I told you, this is the hallmark. Okay, this is the hallmark of goblet cell is the hallmark of Barrett esophagus. Barrett's esophagus. Goblet is the hallmark of Barrett esophagus. The moment you see goblet cell, you are sure it's Barrett's esophagus. Now, the second thing you should know is, metaplasia is not always normal. A metaplasia can change. A metaplasia can change very well to dysplasia, which can then go into adenocarcinoma. So we should also write here the progression. The progression. The Barrett, which is definitely a type of metaplasia, this can go to dysplasia and dysplasia can then progress to adenocarcinoma. It can then go to the adenocarcinoma. Now, this progression is very, very important. It has been multiple times asked the what is the progression there? What is the progression there? A Barrett can go to dysplasia, and dysplasia can very well easily go into adenocarcinoma. So that means, is Barrett pre-malignant? Yes, Barrett is a pre-malignant condition. Barrett definitely is a pre-malignant condition. Okay, it's a pre-malignant condition. Barrett is one topic you'll always find in the exams. So no matter you read it so in detail, it'll always and always help you. Barrett is a very, very commonly seen situation by the surgeons, and is also very commonly seen situations in the pathology as well. Now, I just told, what I told you with this right here, this occurs in the GERD, gastroesophageal reflux disease. So, how does a patient present with? At this point of time, the patient present with the heartburn, the epigastric pain. So, yes, in pharmacology, you will read that it is often relieved by the proton pump inhibitor, the Rantac, the H2 blockers. So the PPI and the beta blockers are often given there to actually relieve the symptoms, but sometimes it doesn't get relieved and eventually can progress to the Barrett. At that point of time, the surgeon has to take a call into some intervention going on there to remove that part of epithelium, else it may go to dysplasia and finally can also go to adenocarcinomas. So any doubt in Barrett's, guys? So hypertrophy can be linked to the Frank-Stall law. Exactly, yes. Frank-Stall law is the exact reason why the hypertrophy occurs. Very good. Any doubt? Okay. Since you're not asking a lot of doubt, at least tell me, is the speed okay? At least that you can answer, right? So if suppose some of you are watching this video, at least tell me if the speed is okay or not. At least have the courtesy of telling me that, because I can't see you, because usually in the classes I can at least see how much my students are following. So if the speed is okay, at least let me know that, because if the speed is okay, I know that you will always understand this, because I go in such a way that you first understand and then you write it. So you have to be more specific which diagram you want to know. Okay, at least the speed is okay. So most of you feel that the speed is okay, then that's okay. Chalo. A few students, I understand the speed may look more because you don't have a, that writing is art. So try to watch and write, and don't wait for the notes to be given to you and then write. Chalo. So I think everything is okay. Then I'll move to the next one. That is, okay, Barrett ka diagram. Dekho beta. This is the Barrett diagram. So देखो, this is the columnar epithelium, red in color. It's a pale looking squamous epithelium. Okay, when the acid goes to the lower part, this area becomes red. When the moment this area becomes red, this is how the inflammation looks like. You take a biopsy from here, and what you see here is this one. Normally from the esophagus, you should see squamous epithelium. Because you're looking at the columnar epithelium and you're seeing at the goblet cell, this becomes a classical case of Barrett esophagus. Chalo, first of all, thanks a lot for at least trying to interact with me. The speed is okay. Then let's move ahead. Okay? We will try to finish this topic. Our next topic will be atrophy. Okay, my next topic would be atrophy. Now let's first define atrophy, guys. The fourth one is atrophy. Okay, atrophy. What exactly is atrophy? Atrophy means there is a decrease in the cell size and as well as decrease in the number. Okay, so atrophy is defined as reduction. It's a reduction in size of the organ. Okay, reduction in size of the organ or tissue. Remember, it's reduction, not increase, it's reduction. Reduction in the size of the organ or tissue. Okay, and why it is happening? Due to decrease in cell size and number. Okay, cell size and number. So because the cell size and number have reduced, the size of the organ has also reduced. Okay, so what are the reasons or the causes of atrophy? There can be some physiological and pathological causes. Let's write the pathological causes first. What are the pathological causes of atrophy? One of them is number one, decreased workload. One of them is decreased workload. The decreased workload which causes atrophy of a tissue, and this often occurs when there is a disuse atrophy. This often occurs as referred to as disuse atrophy. Now, when does it happen? It happens if there's a fracture. This sign is a fracture. I should write it here. This sign I've written, it's a fracture. Okay, fracture of bones. So when there's a fracture of bones, often you might have seen that that part of the bone is put in a cast. It's a concrete calcium cast. So when there's a cast put there, and when the cast is removed after 1 month, that muscle might not have been used. Suppose there's a fracture in the humerus bone, and there would have been, there's a fracture in the humerus bone, and the cast is put here. If the cast is put here, and the cast is remaining there for 1 month, when the cast is removed from here, the muscles look quite thinned out. Why? Because the muscles have not been used. So disuse atrophy. Why? Because of fracture of the muscles, and therefore the cast, there is reduced use of the skeletal muscles, and because of which there is decreased size of the tissue. There's decreased size of the muscle mass. Decreased size of the muscle mass, the first one. Okay, the second one is loss of innervation, nerve innervation. Loss of nerve innervation. Loss of the nerve innervation. Now this is called as denervation. It is called as denervation atrophy. It's referred to as denervation atrophy. Now what is denervation atrophy? First, you write it down. This denervation atrophy refers to a condition where the nerves are cut off. The nerves are often cut off. It often happens to the skeletal muscles. The nerves often have a cut off in the muscles. Okay, in muscles. Example, in muscles. Like in polio, you might have seen. In polio, the nerves are cut off, and therefore the polio muscles quite appear shrunken, right? Third one is diminished blood supply. Diminished blood supply. The diminished blood supply, this example occurs due to ischemia, and this ischemia is seen as an old age change in the brain. It's a diminished blood supply often occurs in the brain in the old age. In the brain in the old age. And this type of diminished blood supply is called as senile atrophy. It's called as senile atrophy. Okay, it's referred to as senile atrophy. Is referred to as senile atrophy, which affects what? It affects the brain. Okay, but it also occurs in the heart also. It may also occur in the heart. Why? Because of atherosclerosis. It may also occur in the heart because of atherosclerosis. The fourth one is diminished nutrition. Diminished nutrition. The diminished amount of nutrition, it occurs because of the protein energy malnutrition. The word we use for that is, protein energy malnutrition, referred to as PEM. Now this is seen as a cachexia. It's often seen as a cachexia. Okay, decreased malnutrition. Sorry, malnutrition is often referred to as cachexia. Again, the muscle mass appears low. The fifth example where you see this is loss of endocrine stimulation. Okay, loss of endocrine stimulation. So loss of endocrine stimulation, for example, which occurs after menopause, the estrogen amount decreases. Let's write it down. Example, in menopause, example, after menopause, there's reduced estrogen, and because of reduced estrogen, what happens? Because of reduced estrogen, what happens? There is a reduction in the size of uterus and the breast. Okay, reduced size of uterus and the breast. Okay, and the sixth one is pressure atrophy. Here what happens? Suppose there is an enlarging size of a organ, or there's a tumor. The tumor enlarging may compress the main organ. So the entire organ will compress in size because of the pressure from a tumor. Okay, because the pressure from a tumor. Okay, so example here, a tumor compressing organ. A tumor compressing a organ. Okay, the tumor compressing an organ. It is pressure. It's called as pressure atrophy. Okay, it's called as pressure atrophy. Now, why does the atrophy occur? Why? The atrophy usually occurs. The reason of the atrophy is because of degradation of the proteins of the cell. Now, have you heard about the ubiquitin pathway? So what happened? The ubiquitin proteasome pathway is a pathway where any protein which has got either damaged or has got misfolded will be removed. Okay, so what happens? Because of the nutrition deficiency or a pressure or a ischemia or denervation, any of these will basically damage the proteins, and that proteins get misfolded or that protein gets damaged, and that damaged proteins is removed by the ubiquitin proteasome pathway. Ubiquitin proteasome pathway, and because of the removal of these proteins, ultimately there is atrophy in the organ. Atrophy in the organ. Okay, let's write it down. The mechanism usually is the damaged oblique misfolded proteins. Damaged oblique misfolded proteins removed by okay, ubiquitin proteasome pathway. Okay, take your time and write it down, no hurry. Okay, ubiquitin proteasome pathway. So the nutrition deficiency, the pressure atrophy, the denervation atrophy, all of them will ultimately damage the proteins, and all the damaged proteins of the cells or the tissues are removed by the pathway, and ultimately the organ shrinks or decreases in size. This organ shrinks or decreases in size. Sometimes there is association. Sometimes, I should say, sometimes atrophy is associated with autophagy. Autophagy. So what is autophagy, guys? Eating up of itself. So when a tissue eats up its own cell, it is called as autophagy. Self-eating. Okay, self-eating. That means sometimes when the tissues are getting atrophied, it is simultaneously accompanied by eating up the atrophied cells, and that happens by something called as autophagy. It happens by sometimes called as autophagy. This is the fourth type of adaptation. It is called as atrophy. Okay, I'll show an image here. This is the atrophied brain. It's a senile atrophy. I told you senile atrophy often occurs when there is a ischemia in old age. So often in old age, what happens? There is a mild amount of thrombotic thrombosis in the vessels. So the vessels supplying the brain often get ischemic, and this is the atrophied area. So what happened? Because this is the sulcus. The sulcus is getting widened, and the gyri is getting narrowed. Narrowed gyri, widened sulcus. Narrowed gyri, widened sulcus. ठीक है, this is what happens in the brain atrophy. It's an example of senile atrophy. I told you senile atrophy can also be seen in the heart. Why? Because of atherosclerotic changes occurring in the heart. This is where the same thing has been shown in the muscles. Here do you see the big muscles? These are normal big muscles. This muscle is getting atrophied here, okay, and this atrophied muscle may be the reason of denervation. So if the muscle have actually lost its nerve supply, all this muscle will decrease in size, and eventually because the muscles have decreased in size and the number, the whole tissue of the muscle will also shrink in size. As this we have read, it occurs in the disuse atrophy or may also occur in the denervation atrophy. Disuse atrophy or may occur in the denervation atrophy. Okay, what is GERD? GERD is gastroesophageal reflux. Okay, has been well answered also. Thank you. Chalo. So let's now move to the next topic, and our next topic will be, if you see this, dekho, till now we have finished up to all the cell adaptations 1, 2, 3, 4. Our next topic should be reversible injury, and this will read today as hypertrophic change. This is the next topic, hypertrophic change, that is reversible injury. Let's start this next topic of reversible injury. So moving to the next topic of reversible injury. Okay. First of all, it should be very clear, when does a reversible injury occur? A reversible form of injury occurs when there is a mild non-lethal injury. Okay, it occurs whenever there is a mild non-lethal injuries. And what are the injury? I told you already. The injury can be mechanical, it can be physical, it can be chemical, it can be radical injury, it can be tissue ischemia. So any of those injuries are included here. In fact, it can also be genetic injuries. Okay, it can also be genetical form of injuries. Now see one thing, whenever you talk about reversible injury, so how does the changes occur? Dekho, let's assume I'm making a graph here. So what happens if I talk about the effect? Okay, there's an effect and there's a duration of injury. Duration of injury. Let's assume initially the injury was reversible. So let's assume this shaded line is of reversible injury. This is reversible cell injury. Reversible cell injury. And this is irreversible. This is irreversible cell injury. Okay. Now what happens? Because of the reversible cell injury, the cell function, it starts to decrease as a. Okay. Now because of the reversible injury, this is a graph of cell function. Okay, this is a graph. This graph is of cell function. The cell function is starting to decrease. Now don't include adaptation here. Adaptation is gone because adaptation doesn't occur because of injury. Adaptation occurs because of stress. It's a different thing. Let's now move to the injury here. First of all, the cell function is decreasing because of the injury. Now, the moment the duration of injury increases, what starts happening? First of all, the first change is always the biochemical changes. Okay, the first change to occur is the biochemical change. This is supposed to biochemical alterations. This is what? It's a biochemical changes. It occurs first. Because of the biochemical changes, there are some electron microscopic changes. The second graph is of electron microscopic changes. So first the biochemical changes occur in a cell, then electron microscopic occurs in a chain. The next thing to occur is a light microscopic changes. I am writing LM changes. And finally, there is a gross morphological change. This is the gross morphology change. So if you look at the duration of injury, what occurs first? The first thing to occur in a cell is biochemical change. Next thing to occur is electron microscopic change. Next to occur is light microscopic change. And finally, the gross morphology of the tissue does change. So this is a sequence of event what happens because of the injury. Okay. Now what we'll do, we'll try to understand the effect of reversible injury on a cell. Okay. We'll try to understand the effect of a reversible injury on a cell. So reversible injury is initially occurring, and by this time the cell function has not gone to zero. It is reducing, it's not gone to zero. Later on, after discussing reversible injury, we'll then move to the irreversible injury. But first, we'll talk about reversible cell injury. Okay, let's start with the topic of reversible cell injuries again. Now this I'll explain to you in a flow diagram. So we'll take at least one page. So make sure that you have enough amount of page, one full page to write the topic. Okay. So what is the mechanism of reversible injury? Mechanism. Dekho. I told you, most commonly it occurs because of mild, non-lethal injury. All the injury I just mentioned, they eventually lead to all the injury eventually leads to mild amount of ischemia. And that mild ischemia, which is reduced blood supply, it causes mild hypoxia, which is reduced oxygen supply. It's reduced oxygen supply. So mild ischemia causing mild amount of hypoxia. Mild ischemia causing mild amount of hypoxia. Okay. Now see, in biochemistry you have read, whenever the amount of oxygen, you have read in biochemistry, whenever the amount of oxygen is less, it leads to what? It leads to anaerobic glycolysis. It leads to anaerobic glycolysis. That means what? It means the glucose is being utilized in the less amount of oxygen. So what is the effect that you must know? The effect is the moment there's anaerobic glycolysis, it will lead to two things. On one side, you all know there's reduction in the ATP production. This you all heard in biochemistry. I told you the first change to occur is biochemical changes. Okay? The first, there's reduction in the ATP. And along with this, there's also increase in the lactic acid production. There's also increase in the lactic acid production. Now, देखो what happens. Well, this ATP, it actually regulates a pump in a cell. The pump is called a sodium potassium ATPase pump. So what I'll do, I'll draw that pump here and write reduction in the sodium potassium ATPase pump. It decreases. The moment the sodium potassium ATPase pump decreases, what is the effect? Let's understand this. Dekho. What I'll do, I'll draw this pump here. Okay. This is the pump in a cell. The function is to put sodium out, take potassium in with the help of ATP. Okay? Put sodium out, take potassium in with the help of ATP. You all know this sodium potassium ATPase pump. Now, the ATP is reduced here. The moment ATP is reduced, what happens in a cell as the ionic changes, increase in the sodium occurs. Increased sodium occurs. So the result of the sodium potassium ATPase pump decreasing is it causes increase in the intracellular sodium. It causes increase in the intracellular sodium. Let's think what happens. If any cell has increase in the sodium in the cell, all the extracellular fluid, ECF fluid, will start rushing inside, isn't it? All the ECF will rush inside. ECF means extracellular fluid. So because of the extracellular fluid rushing inside, what happens is there starts occurring some electron microscopic changes. Okay, let's see what are the EM changes. Let's write it here only. So what are the morphological changes? This was the biochemical changes. Let's now write what are the morphological changes here. Morphological changes. The first change will occur is that of electron microscopy, that is EM changes. See, any cell, if I draw this cell here, any cell surface has microvilli like this. Okay. Similarly, let's assume this cell is a round cell like this. It's a round cell like this, and the round cell on surface has microvilli like this. Okay. Now see, because this is an electron microscopy, because the water is moving inside, the H2 water is moving inside, the cell has enlarged in size like this, as in. When the cells has enlarged in size, all the microvilli will be lost. All the microvilli on the cell surface will be lost. All the microvilli on the cell surface will be lost. Okay, because the microvilli on the cell surface will be lost, what happens? The first change we're writing here is the first change is loss of microvilli. The first change is loss of microvilli. Then what happens? There's a bleb formation like this. Okay, there's a bleb formation like this. Why? These are blebs. Okay, these are the blebs. B-L-E-B-S, blebs. Now, why is there blebs here? Because the cell wants to accommodate more and more water. To accommodate more and more water, see, to accommodate more and more water, it will make blebs. The blebs can accommodate more water. So, the next finding is cytoplasmic blebs. Next is cytoplasmic bleb formation. Why are the blebs? To accommodate more and more water. Once the water is moving still inside, still the water has not stopped moving inside. So now the organelles here will start swelling up like this. This organelle swelling, it may be mitochondria, it may be endoplasmic reticulum. The next finding is organelle swelling. The organelle swelling will include like electron microscopic swelling and the mitochondrial swelling. The EM swelling and mitochondrial swelling will occur. When the ER, endoplasmic reticulum swelling. When the ER swells up, what comes out is this leads to ribosomal detachment. Okay, it leads to ribosomal detachments. Ribosome, you all know, is going up now. Okay, the ribosome we all know will lead to protein synthesis. So this will cause decrease in the protein synthesis in a cell. The moment there is reduced protein in a cell, the cell will be deficient of the energy. Please understand, at the initial finding, the first finding written here is reduction in the ATP. Now, the protein is also reducing. Less ATP, less protein. What other energy source the cell has got? The cell now has got a triglycerides, the fats, to be broken down to produce ATP. Everything is biochemistry. See how it's correlating. Physiology, biochemistry, and pathology. See, it has to break the triglycerides. It has to break the triglycerides to form the free fatty acids, and this will produce the ATP. Now, when the free FFA means fatty acids, okay, this means fatty acids. The free fatty acids, now this will accumulate in a cell. When the free fatty acid accumulate in a cell, it is called as fatty change. Okay, this finding is referred to as fatty change. Now, this is a very, very important finding, biochemical finding you see in a cell, fatty change. Well, if you look at the top finding here, this was increase in the lactic acid. Lactic acid was there. So biochemically it will cause decrease in the pH. Will cause decrease in pH. And once the pH has reduced, the reduced pH will cause what? Will cause chromatin condensation, because the DNA will shrink and the shrunken DNA will cause chromatin condensation. The shrunken DNA will cause chromatin condensation. The shrunken DNA will lead to chromatin condensation. Okay, will lead to chromatin condensation. Okay, please understand, till now this finding was electron microscopic changes, EM changes. Okay, now I told you the first change is biochemical change, next change is EM change, and what is the next change, guys? Light microscopic changes. I'm writing it here just below it. What are the light microscopic changes occurring in the cell? Very simple. The EM changes is what will cause the light microscopic changes. So what happens in the EM was the water was moving inside a cell. So there was a loss of microvilli and was a bleb formation. Eventually you see, when the water is going inside a cell, the cell size should happen what? The cell size should increase. Why? The cell is accumulating more and more water. The first thing you will see here is cell swelling. It is cell swelling. The first thing you'll see is cell swelling. Okay, when the cell swelling is occurring, why? Because the water has moved inside. The water moving inside will allow a cell not to stain the pink usual stain, but because water doesn't stain at all, it will appear pale in color. What I'm trying to say is, let's assume there's a cell here. Okay, there's a cell. Okay, there's other cell, and there's chain of cell like this. Okay, this is a nucleus, guys. A small nucleus like this. Now understand. Once the cell swelling has occurred, the cell swelling will occur like this, as in the big cell here. Now, what are the changes you expect? First of all, the chromatin will condense. Why? Because of decrease in pH. Look at the condensed chromatin like this. Condensed chromatin. Now, please understand. Normally any cell stains pink. As in, normally all cells cytoplasm stains pink, but this won't stain any pink. It will stain very pale like this. It will stain very pale in this manner. This pale color staining looks like a cloud, isn't it? The pale color staining, it looks like a cloud, and because of the cloudy staining, the cloudy staining is called as cloudy swelling or the hydropic change. Okay, it's called as cloudy. It's called as cloudy swelling or hydropic change. It's called as cloudy swelling or referred to as hydropic change. Cloudy swelling or the hydropic change. Okay? Now this is the light microscopic changes. These are the light microscopic changes. So easily mentioned. So please understand, when you read a textbook, you won't find these flow diagrams. You'll find big paragraphs. I have just changed those paragraphs to easy to learn flow diagrams. The moment you read this, you have that concept building in the mind, and this will help you to retain it better and will help you to understand the few upcoming chapters even more better. Okay? I'll try to first revise this before you have any confusion here. Dekho. The first thing to happen here is the mild non-lethal injury. Mostly the injury causes ischemia. Ischemia causes hypoxia. Hypoxia causes anaerobic glycolysis. The anaerobic glycolysis has two effects. On one side, reduce ATP. On the other side, increase lactic acid. I am first starting with the effect of reduced ATP. Reduction ATP decreases a pump called as sodium potassium ATPase pump. The moment the pump is decreased, the sodium content increases, because of which water moves in a cell. So there are some EM finding here. First of them, when the water moves inside, the cell swelling occurs. This causes loss of microvilli on the surface, and to accumulate more water, the cell develops some cytoplasmic blebs. These blebs will accumulate more and more water. When the water moves inside, the organelles also start swelling. The two important of them is mitochondria and ER. So when the mitochondria in the ER swells up, the ER swelling will cause ribosome to detach. The protein will decrease. The cell already is in a state of less amount of ATP. Less amount of protein should be now dead by breaking the triglycerides to form free fatty acids. Well, it is called as fatty change. Okay, fatty change. Now, because of increase in lactic acid, the pH has reduced and the chromatin has already condensed. Looking at this, let's see the light microscopy. LM means light microscopy changes. This is the normal cell. When the water moves inside, the cell starts turning pale. And this pale color looks like a cloud, and hence the name is cloudy swelling. The name is cloudy swelling. Okay, the name is called as cloudy swelling. Okay? The cloudy swelling or the hydropic change is there. It is. The cloudy swelling and the hydropic change is what you see here. Well, let's see this whole finding in a microscope. Hydropic change. Look at this one first. This is how a normal hepatocyte looks like. These all are the images of the normal hepatocyte. Look there, guys. This is a normal hepatocyte. This is one cell. The second cell. Normal hepatocyte. First year histology, not pathology. Okay. These all are hepatocytes arranged one beside the other, like called as cords of hepatocytes. Color of the nucleus is blue and cytoplasm is pink. Okay. Cytoplasm stains pink, I'm C, and nucleus stains blue. Okay. This is the normal color of these cells here. Okay. Anyhow, now this is a normal hepatocyte. Compare this hepatocyte to any of the cell here of your choice. Take any cell of your choice. Let's take this cell. Look at this one. Look at this one. Look at this one. What you're seeing is all the cells are now staining pale. Look at the whitish color here. Look at the whitish color. Look at the condensed chromatin. The white color cell, it is called as hydropic change. The hydropic change is a finding which you see, and this is indicated the cell has undergone a reversible injury of the hydropic change nature, also called as cloudy swelling. The chromatin has condensed, cell size has reduced. So findings of the light microscopy you see in this image are cell size increased, chromatin condensed, color pale. The pale color is called as hydropic change or cloudy swelling. Okay? Now see this as an electron microscopy changes. Now this is an image of the proximal tubule of a rat. EM image of the proximal tubule of a rat undergoing reversible injury. This is a normal image. Now this is a tubule cell. So in the tubule, this big one is a nucleus, guys. It's an EM finding. Okay, it's an electron microscopy finding. It's a nucleus. These all small are the mitochondria. This is the microvilli. Okay, these are all my microvilli, and this L is a lumen. Okay, L is a lumen. So based on this, this is a normal finding. It's a normal. Compare this finding to what you see here. Now compare these two. Dekho. This is the normal finding. Look at this was the normal. Now look here. The chromatin has condensed. Look at the condensed chromatin here. Condensed nucleus chromatin here. Okay. These are what? These are the blebs. They're blebs here. Okay. And look at the swollen up mitochondria here also. And microvilli over here. Here you see there's no microvilli here. The microvilli are completely lost. So loss of microvilli, bleb formation, condensed nucleus seen both in the light microscopy and the electron microscopy, and you see the mitochondrial swelling. Again I repeat, loss of microvilli, bleb formation, nucleus condensation, organelle swelling. Organelle swelling. These all are the findings you expect in the reversible injury findings. These all are the findings you expect in the reversible injury findings. Reversible injury findings. Okay, so when you see these images, don't just look at the image and get astonished. Look at the image, try to learn the image in the conceptual way so that you don't even need to look at the textbooks again. You cannot read the textbooks again, but what you can read definitely is your own notes. So when your notes are made in such a beautiful manner, written everything in a flow diagram, this whole thing you won't believe is 3 pages of Robbins. 3 pages written in one single flow diagram. And when you read this, you don't need to read anything else. Even when you read the textbooks, you won't get this concept because there the things are written in a complicated way. And this is what simplified version is. Okay, so read this thing, read this, then look at the image from the textbooks, and then try to look at the whole textual manner. You will get something extra, but believe me, those are not as important. Important stuffs are here. You can read the textbook. You should read the textbook, no doubt about it. Because I know I get these doubts many a times. I get a doubt, sir, how should I read a textbook? My way of teaching is know the concepts, read them clearly, see the image from the textbooks, and yes, if you have time, if you want to, read the entire text of the textbook. Yes, you will get many things extra. Don't feel faculty or me have missed it. I have not taught you that because those are not important. Okay, and this statement comes from a long experience. So believe in me, because this is an area, it's a teaching where the faculty matters the most. Okay, there may be good things about it, there will be some bad things about it, but ultimately what matters is the faculty able to teach you these things. Okay, now this was about the reversible injury finding, and next we'll move to the irreversible injury finding about the necrosis and the apoptosis. But right now, this is about the reversible injuries.